Autoimmune hepatitis is a chronic autoimmune disorder that causes inflammation of hepatocytes. The major causative event in pathogenesis of autoimmune hepatitis is loss of tolerance against their own liver antigens. We can divide the pathogenesis of autoimmune hepatitis on stages. Initially, autoimmune inflammation causes acute hepatitis. Then progressive inflammation will induce massive fibrosis. In this case, fibrosis serves as a protective reaction. Progressive fibrosis at some point will cause cirrhosis, and cirrhosis can be complicated by hepatocellular carcinoma. Currently, we have two types of autoimmune hepatitis. The first type occurs usually in adults, and the characteristic feature of type 1 autoimmune hepatitis is the presence of antinuclear antibodies and anti-smooth muscle antibodies. Type 2 autoimmune hepatitis occurs in young age. It's a more severe type with worse prognosis. And the major diagnostic feature is the presence of anti-liver kidney microsomal type 1 antibodies. So let's explain the pathogenesis of autoimmune hepatitis. We have liver tissue. Liver tissue is composed of hepatocytes. Inside the hepatocytes, we have various organelles with intracellular enzymes. Hepatocytes are not immortal cells, so with time, old hepatocytes die by apoptosis, and immediately they are replaced by new hepatocytes. With apoptosis, hepatocytes release intracellular content into their extracellular environment. Its nucleus, intracellular enzymes, and smooth muscle cells. Let's call them liver apoptotic debris. The major problem with apoptotic debris is high immunogenicity. For example, in normal condition, nuclear material is contained inside the cell under the nuclear membrane. But with apoptosis, now intracellular material becomes exposed. Once hepatocytes release apoptotic debris undergo phagocytosis by macrophages, and then macrophages present some parts of the apoptotic debris on MHC2 receptor to T helpers. The logic is that antigen-presenting cells want to know, is apoptotic debris normal material or it's something pathogenic? T helpers scan liver apoptotic debris, and in normal condition, T helper recognize them as normal substances, and thereby they do not trigger inflammation. But some people have MHC2 receptors that are produced based on HLA-DRB1 alleles. And in this case, most probably, inflammation will develop. And to understand why, we have to know how antigen presentation occurs. In normal condition, when liver apoptotic debris is released, macrophage intakes apoptotic debris in order to present it to T helpers. And antigen presentation occurs by an MHC2 receptor. What we have to know about MHC2 receptor is that it's a protein. And the genetic information that tells us how to make MHC2 receptor is contained in the gene that is located on chromosome 6, and we call this gene HLA-DRB gene. But we have different variations of HLA-DRB genes, and such variations we call alleles. The simplest analogy is the eye color. You see, we all have genes that encodes the color of our eyes. But some of us have blue eyes and some of us have black eyes. And in this case, genes that encodes blue eyes we call blue allele, and genes that encodes black eyes black allele. So we all have genes that encodes eye color, but this gene can be different, and different variations which are blue and black colors of the same gene that in this case encodes eyes we call alleles. So in case of autoimmune hepatitis, we all have genes that encodes MHC2 receptor. We call this gene HLA-DRB gene. But this gene can be different, and different variations of HLA-DRB gene we call HLA-DRB alleles. For example, if person has HLA-DRB2 allele, this person will have MHC2 receptor that was made based on genetic information in HLA-DRB2 allele. And such MHC2 receptor presents apoptotic debris in a perfectly normal way. And when T helpers income to this receptor, They recognize apoptotic debris as a normal substance, and because of this, they do not see any danger. If person has HLA-DRB4 allele, this person will have MHC2 receptor that was made based on genetic information in HLA-DRB4 allele, and such MHC2 receptor presents apoptotic debris also in a perfectly normal way. Thereby, there will be no inflammatory response. If person has HLA-DRB5 allele, this person will have MHC2 receptor that was made based on genetic information in HLA-DRB5 allele, and such MHC2 receptor also presents apoptotic debris in a normal way, so there will be no inflammatory response. But some individuals have HLA-DRB1 allele. Thereby, in this case, person will have MHC2 receptor that was made based on genetic information in HLA-DRB1 allele. The problem is that this particular MHC2 receptor do not know how to present apoptotic debris to T helpers. When T helpers income to MHC2 receptor, in this case, because apoptotic debris is presented in abnormal way, they cannot recognize it, and thereby they think that it's antigen. In response to any antigen, T helpers immediately becomes activated, and subsequently they differentiate into different subtypes that will induce massive inflammation inside the liver tissue. So in individuals that have HLA-DRB1 allele, MHC2 receptor presents liver apoptotic debris in abnormal way, and because of this, T helpers recognize it as antigen, and in response to antigen, T helpers becomes activated. First of all, T helpers differentiate into T helper type 2 cells. Type 2 T helpers cause activation of B lymphocytes. If B lymphocytes becomes activated, they begin to produce antibodies. First of all, they produce antibodies against nuclear material. We call them antinuclear antibodies. Also, they produce antibodies against intracellular enzymes. We call them antibodies against soluble liver antigen liver pancreas. B cells can produce antibodies against liver microsomes. We call them liver kidney microsome type 1 antibodies. And also, B cells produce antibodies against liver smooth muscle cells. We call them anti-smooth muscle cells antibodies. Antibodies cause severe direct injury to liver tissue that results in destruction of hepatocytes. Also, with activation, T helpers differentiate into type 1 T helpers. T helpers type 1 activate T killers, and with activation, T killers infiltrate liver tissue, which cause severe liver injury. Some T helpers with activation differentiate into type 17 T helpers. Type 17 T helpers produce TNF-alpha and other cytokines, which stimulate B lymphocytes to produce more antibodies. And the last subtype of T helpers is regulatory T cells. But the problem is that in these circumstances, under the massive pro-inflammatory stimulation, they become dysfunctional, so they cannot suppress this pro-inflammatory state, and thereby they cannot prevent liver injury. To explain the clinical symptoms of autoimmune hepatitis, we have to recall the function of hepatocytes. First of all, hepatocytes provide detoxification of ammonia. They convert ammonia molecules into urea, which is a less toxic substance. Also, hepatocytes provide conversion of free bilirubin into conjugated bilirubin. And as we know, conjugated bilirubin is substantially less toxic substance. In addition to this, hepatocytes produce coagulation factors. Coagulation factors provide normal coagulation, and recall that we measure coagulation by activated partial thromboplastin time, prothrombin time, and international normalized ratio. In autoimmune hepatitis, severe liver injury causes massive hepatocytes death. With death, hepatocytes release intracellular enzymes. It's ALT, AST, and GGT. So the level of liver enzymes in the blood will increase. Also, with death of hepatocytes, the detoxification of ammonia decreases. This causes increase in blood ammonia level, and increase in blood ammonia can cause hepatic encephalopathy. In addition to this, with hepatocyte death, bilirubin that was inside the hepatocytes now enters into the blood, and the increase in blood bilirubin level can cause jaundice. With decreasing amount of hepatocytes, the production of coagulation factors decrease. Without coagulation factors, coagulation cascade is not working, and disrupted coagulation cause prolongation in partial thromboplastin time, prothrombin time, and international normalized ratio. Also, severe inflammation inside the liver tissue cause irritation of the foregut autonomic nerves, and irritation of nerves manifests as pain in the right upper quadrant of the abdomen. In autoimmune hepatitis, autoantibodies plays crucial role in diagnosis, so we have to know them. Antinuclear antibodies and anti-smooth muscle cells antibodies are the most common in autoimmune hepatitis type 1. So antinuclear antibodies and anti-smooth muscle cells antibodies are the characteristic features of hepatitis type 1. In contrast to this, liver-kidney microsome type 1 antibodies are the most common in type 2 autoimmune hepatitis. So liver-kidney microsome type 1 antibodies are the characteristic features of type 2 autoimmune hepatitis. Also, sometimes Pianka can be positive, but because Pianka is also present in primary sclerosing cholangitis, it's a non-specific marker. Antibodies against soluble liver antigen liver pancreas are also positive in both hepatitis type 1 and type 2. So antibodies against soluble liver antigen liver pancreas tell us about the presence of autoimmune hepatitis, but they do not tell us about the type of autoimmune hepatitis because they are present in both types. There are also other less common antibodies, as anti-LC1 antibodies or anti-liver-kidney microsome type 3 antibodies. They are typically positive in type 2 autoimmune hepatitis. But important that if antimitochondrial antibodies are positive, in this case, typically we think about primary biliary cholangitis. Also in this case, there is a small possibility that it can be overlap syndrome, which is the presence of primary biliary cholangitis and autoimmune hepatitis in the same time. If we have to compare different types of autoimmune hepatitis, we can see that type 1 affects mostly adults, and type 2 most commonly affects children and young people. In type 1, typically, we can determine positive antinuclear antibodies and anti-smooth muscle cells antibodies. For type 2, the most specific antibodies are liver-kidney microsome type 1 antibodies. Type 1 autoimmune hepatitis is more common, and as we see, they both are associated with other autoimmune extra-hepatic disorders. It can be Graves' disease, it can be lupus. Basically, the presence of one autoimmune disorder greatly increases the risk of other autoimmune disorders. Type 1 autoimmune hepatitis is less severe and thereby has better prognosis. Type 2 is more severe, so it has worse prognosis. And also, type 1 autoimmune hepatitis typically has good response to treatment, but type 2 hepatitis long-term more frequently causes liver cirrhosis, and thereby liver transplantation is more common in type 2 autoimmune hepatitis. Nowadays, to diagnose autoimmune hepatitis, we use diagnostic criteria. Actually, we have two of them, full version and simplified version. So let's explain the full diagnostic criteria. The first criteria is female sex, because as we know, autoimmune disorders most frequently affects females. The second criteria is elevation of intracellular liver enzymes, it's ALT and AST, and also they should be higher than ALP. The logic is that elevation of ALT and AST tell us about injury to hepatocytes, what actually happens in autoimmune hepatitis. And in contrast to this, ALP tell us about the pathology in the biliary tract, typically it's cholestasis. The third criteria is elevation of gamma globulins due to the increase in immunoglobulin G fraction. The logic is that antibodies in autoimmune hepatitis are typically immunoglobulin G antibodies. Because all antibodies belong to gamma globulins, on electrophoresis we can determine increase in gamma globulin fraction. And because the increase in gamma globulins is caused by immunoglobulin G antibodies, on immune fixation we can determine increase in immunoglobulin G antibodies. The fourth criteria is increase in autoantibodies, which are specific to a certain type of autoimmune hepatitis. As we know, in type 1 autoimmune hepatitis, it's antinuclear antibodies and anti-smooth muscle cells antibodies. In type 2 autoimmune hepatitis, it's liver-kidney microsome type 1 antibodies. And in both types, we can find antibodies against soluble liver antigen liver-pancreas. The fifth criteria is criteria of exclusion. If antimitochondrial antibodies are positive, probably it's not autoimmune hepatitis, because antimitochondrial antibodies are the characteristic features of primary biliary cholangitis. The next criteria exclude other possible causes of hepatitis. So we can know for sure that it's not viral hepatitis, not drug-induced hepatitis, and not alcoholic hepatitis. The seventh criteria is a genetic predisposition. And genetic predisposition we can determine based on HLA genes. We know that people with HLA-DRB1 alleles are more predisposed to autoimmune hepatitis. The next criteria is the presence of other autoimmune disorder. Basically, we know that the presence of one autoimmune disorder greatly increases the chances for the second autoimmune pathology. So, for example, in person with Graves' disease, the risk of autoimmune hepatitis is significantly higher. The ninth criteria is histological features. It's the presence of inflammation in liver tissue, presence of plasma cells, and rosettes. We know that autoimmune reactions cause significant injury to hepatocytes that cause inflammation. And inflammation in the liver tissue we call hepatitis. And the crucial cells in pathogenesis are activated B cells because they produce autoantibodies. Activated B cells we call plasma cells. So here we can see massive infiltration of the liver tissue by lymphocytes. On this image we can see activated B lymphocytes, so-called plasma cells. Massive inflammation in liver tissue provokes regenerative reaction, and areas of regenerating hepatocytes we call rosettes. On this image we can see areas of hepatocytes necrosis, and also there is massive lymphocytes infiltration. And here we can see plasma cells, which are the key cells in pathogenesis of autoimmune hepatitis. The last criteria is the treatment response. If there is good response to a specific autoimmune hepatitis treatment, then probably we guessed it correctly. But what is the treatment? Currently, in treatment, we use two major medications. It's corticosteroids and azathioprine. But as we see, the major medication is corticosteroids. The reason is that corticosteroids as prednisolone induce apoptosis of lymphocytes. And because lymphocytes are the key players in pathogenesis, with decrease in lymphocytes, the severity of inflammation decreases. And the lower is the inflammation, the less severe is the injury to liver tissue. But also, we have simplified criteria that basically tell us the same. First of all, to make a diagnosis of autoimmune hepatitis, we need to determine specific autoantibodies. Also, we have to determine increase in gamma globulins due to the immunoglobulin G fraction. We have to determine a specific histological features and exclude any other cause of hepatitis. Nowadays, we have new medications for autoimmune hepatitis. They are not in the guideline, but sooner or later we will use them. The first medication called abatacept. This drug inhibits activation of T helpers. Abatacept blocks activation of T helper, and by this we can prevent differentiation of T helper into the subtypes. So basically, we can inhibit every inflammatory pathway that leads to a tissue injury. The next drug is rituximab. Rituximab is anti-CD20 antibody. CD20 receptors are located only on B lymphocytes. So with infusion of rituximab binds to CD20 receptor and induce apoptosis of B lymphocytes. And with decrease in B lymphocytes, the production of autoantibodies decrease, and thereby the severity of injury will decrease. And the third drug is infliximab. Infliximab inhibits TNF-alpha. With infusion, infliximab blocks TNF-alpha, and without this cytokine, the production of autoantibodies by B lymphocytes slows down, and the lower the amount of autoantibodies, the less severe is the tissue injury.